Telepsychiatry can benefit patients in a number of ways, such as improve access to care that might not otherwise be available, for example, in rural areas, and bring care to the patient's location. Telepsychiatry enables distance supervision of general practitioners, psychoeducation of caregivers and patients at the general practitioner's office, decreasing stigma of the patients and self-stigma of general practitioners as well. Improved collaboration between public and private sector may lead to better quality of care. We may not forget that stigma is the reason why at least 60% of all mentally ill never access the mental health systems. But if we offer telepsychiatry within general practice office, or even better in the privacy of patient's own home, we will probably reach a greater number of otherwise hard to reach populations, such as stigmatized children and youth, autistic persons, individuals with physical impairment, inmates, patients who avoid transportation due to phobia, ethnic minorities who does not speak the language of the host country. Finally, detained patients have right to get independent clinical opinion in the processes of detention, appeal, and enforced treatment. Finding independent expert in local area may be difficult, but technology knows no barriers. Telepsychiatry may reduce potential transportation barriers, such as lack of transportation or the need for long drives or phobia related to the transportation. Please take a look at following video to get an impression of difficulties that an agoraphobic patient experiences in daily life. You may imagine that such patient may benefit from home telepsychiatry. People with a relaxed relationship with alcohol and drugs can risk driving drunk or stoned and causing serious harm to themselves and others. Telepsychiatry may prevent such scenarios. Telepsychiatry reduced the need for time off work, childcare services, etc. to access appointments far away. Accordingly, telepsychiatry reduced no-show rates and decreased the risk of missing appointments. Telepsychiatry reduces direct and indirect costs and increases quality of life when compared to in-person care delivery. And we may not forget its impact on climate changes. No driving no CO2 emission. Early detection and prevention are improved due to increased access to relevant care and resources. Remote treatment eliminates the risk of becoming infected or spreading infectious diseases to others when sitting in the overcrowded waiting room. COVID-19 is the latest, but not the only potential disease that patients and/or doctors can transmit to each other. Continuity of care is just as important as care itself. Seeing the same therapist, regardless of the patient's location, is now possible thanks to the technology. Meetings take up a lot of our time. Efficiency could be increased by implementation of video conferencing into working routines. Psychiatrists are at the risk of experiencing burnout due to emotional stressors related to the nature of the clinical work, occupational hazards, changing nature of service delivery, and increasing administrative pressures. Telepsychiatry may act as one way to enhance psychiatrists' well-being and job satisfaction through the flexibility it offers. Telepsychiatry may reduce the risk of burnout through creating an increased sense of control over the psychiatrist's schedule. Further, through its remote nature, telepsychiatry reduces some of the occupational hazards associated with the practicing psychiatry toward violent or agitated patients and difficulty fully detaching oneself from the emotional stress of in-person patient encounters. A shortage of doctors, especially in small towns in rural areas, means patients can get timely care. However, telepsychiatry helps recruitment of scarce resources so that relevant care is easily accessible to previously underserved areas and patient populations. In comparison with advantages, there are only few limitations related to telepsychiatry. General disadvantages are primarily related to limited opportunities for somatic examination. However, this may be improved by improved collaboration with general practitioners, so-called shared care model that we already mentioned earlier, or psychiatry nurse and young doctor visiting the patient at home and performing somatic examination. Usually we meet the patient for initial interview in person and perform the somatic examination. However, initial in-person meeting is not mandatory and depends on the doctor's experiences and skills related to telepsychiatry. Electric power failure or disrupted internet connection are unpredictable obstacles. In order to avoid potential complications, we must have prepared a backup plan that involves other real-time communication equipment such as telephone. Further, it may be necessary to reschedule the consultation. Potential consequences of practicing telepsychiatry are occupational, social, and academic isolation. To prevent this, the clinician must actively plan social activities. Moreover, engage in activities beyond work, such as personal interests and hobbies. Incorporate the combination of telepsychiatry and in-person psychiatry, so-called hybrid model, as a way to take advantage of the convenience and flexibility of video conferencing while avoiding isolation. More specific limitations are related to home telepsychiatry setting, which is clinically unsupervised setting. It means that the patient is seen in his own home without any medical staff readily available. In such a situation, the telepsychiatry limitation may be caused by the patient's potential personality disorders. Some patients may record the session and publish it on internet. That is why we must, prior to each session, remind the patient that no recordings are allowed. It is mandatory to have a signed consent prior to the course of telepsychiatry. Mobile devices are accessible and affordable. This makes them perfectly positioned for the delivery of home telepsychiatry. However, such an approach has more disadvantages in comparison with institutional telepsychiatry. Technical limitations of home telepsychiatry are related to equipment selection. Video platforms installed on patients' mobile devices operate via a built-in camcorder. Such a camera does not allow pan, tilt, and zoom functions. Consequently, it results in limited ability to read the patient's body language. Further limitation of built-in camcorder is a mirroring picture. Left is right and right is left. We notice it typically by the letter inversion on the patient's t-shirt. Mirroring picture is non-significant obstacle as long as the clinician is aware of this phenomenon. But if not, then it may play a significant role when the patient, for example, presents left-sided paresis due to stroke, which shows to be right-sided paresis once we meet the patient in person. That is why it is important to be aware of mirroring effect while observing the body language. On many video softwares on mobile devices, the mirroring is turned on by default. However, not all video platforms do have a button for turning the mirroring off. That is why the standardization, interoperability, and intercompatibility between different video platforms and standalone equipment are some of the main challenges for the video equipment producers. The use of pan, tilt, zoom standalone video equipment is the only way to read body language during a telepsychiatry session. Example of telepsychiatry golden standard we may demonstrate through following video. Here you can see how much of the body language we may observe while talking to the patient and simultaneously use the remote control functions. As you see, we can come much closer to the patient without he notice it than we could do during in-person consultation. However, we cannot expect patients to buy the expensive standalone video equipment, but over time, equipment prices will continue to fall. Hopefully, within a few years, standalone equipment will be far more affordable, making it possible to increase the quality of video performance, primarily in the home telepsychiatry settings. Unfortunately, during COVID-19 time, we have seen a number of mental health institutions using video platforms and devices with built-in camera or simple webcams instead of standardized pan, tilt, and zoom equipment. Use of such equipment limits the reading of body language and may adversely affect patient and physician satisfaction and willingness to practice telepsychiatry in future. Telepsychiatry is apparently a valuable tool capable of increasing the access to care and its quality, enabling remote exchange of expertise. But the benefits of telepsychiatry may be fully achieved only by clinicians with relevant skills and competencies related to the use of the technology. Competence training should be a mandatory prerequisite for the use of technology in daily practice. We may not drive the car without a driver's license, even when we are good drivers. To maintain and even increase respect for our profession, we may not perceive technology as something that anyone can use without basic knowledge and skills. Unfortunately, that is exactly what we have seen in the case of telepsychiatry ever since the current pandemic outbreak. Frameworks for telehealth training and faculty development already exist, although few have been implemented today. WPA Telepsychiatry Global Guidelines, as well as this course, are only the beginning. The urgent need for clinical training and skills building around telepsychiatry, as well as other mental health applications such as mobile apps, artificial intelligence, virtual reality, etc., will determine the influence that psychiatry can have in addressing the mental health sequelae of the current pandemic. Offering digital literacy and telepsychiatry competencies training can ensure that all clinicians have the knowledge and skills necessary to work at full capacity through new digital media. Telepsychiatry must be perceived and promoted as a supplemental tool to our traditional daily practices. Once we become familiar with the basics, we will realize that we have never been introduced to the tool that requires so little, while in return it gives us as much as is the case with telepsychiatry. Thank you for your attention.